We're gonna
Kids
be,
look familiar.
I can't wait to come back. I'm excited.
This kid is one from here.
Yes, one of my babies from there. There's lots of them in this slideshow. Yes, that was one
Yeah,
of ours
looks
that we did there.
familiar.
He was so cute. He held that stuffed animal all the time. So sweet. I was looking for nursing from the hospital. I don't see them.
I'm not sure if they're joining today.
Okay, it's busy. Yeah.
Yeah,
Okay, let me go ahead and get started then. You can turn your camera off if you want. You don't have to, whatever you want to do.
no problem.
I'll record it, of course, and then share it afterwards. So like I said, today we're just going to tie up some loose ends, talking about things that we have somewhat touched on, but more from a nursing perspective, moving from the anatomy of congenital heart disease and surgery to things that we need to be doing in the ICU. And sometimes I think it's hard for physicians. They've had a different training, obviously, to kind of
Yeah,
break it down for us to understand, okay, I don't necessarily need to know every single bit of physiology. I need to know how to take care of these babies, right? So we're going to talk about some of that practical stuff today while we're talking about everything.
okay.
So we'll talk about chest tubes a little bit, how we need to be stripping them. We already had a video on stripping them, and of course, we'll go over it again in March. But the reason why we need to strip them, we're going to talk about. And then also the day that's happy day when it's time to come out. We'll talk about that a little bit. We'll talk about how to recognize if there's post-operative bleeding or something that we need to be concerned about. Fluid management. So how important it is to be managing our eyes and nose and keeping track of how much these kids have had in and out. And we'll talk a little bit about that and the reasons why. And then pain control, of course, is a big one after surgery. The kiddos in Guyana are quite resilient and definitely did not need as much pain medicine as I was used to from our kiddos in the States. So that's very interesting. But absolutely, they've had their chest cut open, right? So that hurts. And we're going to talk about pain management and the things that we can give them and how to give those things a little bit. And then getting them up and walking them, getting them out of bed, working towards changing their medications from infusions to medications that are intermittent, and then to oral medicines. Many of them will go home on Lasix and digoxin. So we'll talk about that a little bit. When to change the dressings and how long to leave dressings on, and then also nutrition. And nutrition is one of the biggest things that's so very important. When we have a kiddo that's really sick after surgery, especially those that are on the ventilator, sometimes we don't think about that as much. So it's really important as an ICU nurse to be processing how can we get this kid some calories, some active calories, so that they can begin their healing process, because that really does make things move along better. This was one of our kids actually in the Dominican. He had that little mustache pacifier. I thought that was so funny. I've seen him since then a lot more, but I thought that was so hilarious that is that part of the pacifier. He was so cute too. So chest tubes, we talked about several months ago, and I showed you guys the video about stripping the chest tube. And the reason that we need to do that is because very often kids are so resilient, they will not show that they're bleeding until they're falling off the cliff. And so one of the things that we can do every hour, and sometimes more often, is to strip that chest tube, because if the last hour it had 10 mils out and it was a little bit of a serous sanguinis type quality, and then this hour you're having to keep stripping and you see bright red blood, then that is absolutely an indicator of some sort of post-operative bleeding. And so we need to be the ones that are paying attention to that. And of course, the surgeons, when they come around, will be asking questions about the chest tube output as well. What is the amount of chest tube output, and then what is the quality of it? Often it's bright red after surgery, because it is having around the surgical area, having some fresh bleeding, but that should not stay that way very long. It should get serous sanguinis and then be more serous towards the time that we're talking about pulling the chest tubes out. So we absolutely need to be watching that really closely, because kids won't show us with their heart rate until they're very anemic, and they can become pale, but that's not something that happens early either. So these are all things that we can kind of look for early, and stripping that chest tube is important. Also, like I talked about, the output. And the output isn't necessarily like our urine, where it's a certain number of milliliters per kilogram. It's more that we're just watching hour to hour to have a trend. So if we have a 10-kilo kiddo that comes back from surgery, and the first hour he has 50 mils, then that's just something that we know it's not necessarily too much or too little if everything else is okay with his hemodynamics and his heart rate. But the next hour he has 0, or the next hour he has 200, that's a huge difference, right? And so that's why we need to be monitoring that very closely. And like I said, often if you have a kiddo that's bleeding a little bit more or having a little bit more output, we will be stripping that more too, to make sure, first of all, to keep the tube patent, but also to make sure that we're not missing something from a bleeding standpoint. And then the dressings. Dr. Soto is very particular about dressings. And of course, all of us that come on the trip will remind you guys about this, and we will be assisting. Changing children's dressings is not fun. It's not something that they just love. It's not something that they generally will hold still for. And so we'll have lots of hands on deck, because the kids are also stronger than us. We will often find that a kiddo who's 3, like this little boy here, he can outmuscle 4 of us nurses. And so we will work together on changing those dressings for the chest tubes as well. Usually all the things that stay in, the chest tube is going to be one of the longest ones. Aside, the pacing wires are usually in a little bit longer too than our central lines or our arterial lines. And so those dressings can get kind of yucky. And so keeping that clean and changing that is very important as well. It'll definitely be something better to be doing when we're on site in Georgetown, talking about changing those dressings together and keeping that area occlusive. Now, these are not so much important as far as, like, they're not in the lung, right? They're not inserted for pneumothoraxes. So yes, you want the dressing to be occlusive, but it's not like when they're in place and the dressing is occlusive that they can actually get an air embolus or anything like that through this kind of a chest tube. They're put in the mediastinal space after the surgery. So they're draining that excess fluid that's around the surgical area and the heart, right? But if fluid stops coming out of those, we also have to worry then about things like tamponade, which we'll talk about here in a little bit. There's always going to be a little bit of a process of the body trying to get rid of fluid after any kind of surgery. And so when that happens and if the chest tube becomes occluded for some reason or clotted for some reason, and that fluid doesn't come out, then it builds up around the heart. And that can cause all sorts of other problems that we'll kind of touch on a little bit briefly today. But those are the reasons why we're checking on those chest tubes so often and why the surgeons are asking about them. When we get the daily chest x-rays, that's also something that everybody looks at. Now with babies, even little babies that we're getting out of the bed to hold, which of course we want to do that when we're able to, and we want the parents to be able to hold, that kind of movement, even though the tube is sutured in, y'all, sometimes that can cause movement of the chest tube itself. And so that's something that we watch with the daily x-rays too. Are they basically in the same position? Are they not moving or migrating at all? Because that's important as well. If we had one like on post-op day 2 that quit draining altogether, we might think it's clotted, or we might think maybe it moved a little bit and it's not in the mediastinal sac anymore, or in that area. All of these, like I said, pretty much from today are babies from Guyana. So I just love their little faces. They're so cute. And they've all got their clean dressings. I made sure to pick those out too for y'all. For fluid management, as well as the chest tube drainage and the urine output, we are watching how much fluid we're giving them too, right? Many of these kids will have a need for fluid after surgery. However, depending on what heart disease they had and what surgery they had, that's not something that we want to overload them with, because you guys know if we start overloading them, they're going to have capillary leak. They're going to get really, really puffy. And we don't want to have to do that for the work of the heart as well. So many of them will put on maintenance fluid to begin with, but if we have this kiddo that comes back from a VSD repair and about 2 hours, after being back, he wants to take his first bottle, and he does really well with that, then we need to be talking to the intensive care doctors and the surgeons about adjusting that fluid, because we don't want to overload them. With kids, you guys know they have a daily requirement of what we call their maintenance fluids. And we need to be calculating each hour about how much of their maintenance that they're getting. If a baby takes 8 ounces, obviously you guys know that would be a lot more than what an hourly maintenance would be. So we kind of divide that out and make sure that they're not on also full IV fluids, because you could see how easily that could fluid overload them. So we'll be looking at those calculations every hour in the ICU, and it becomes a little cumbersome. You feel like, oh my gosh, I just did this, when you're sitting there with your flow sheets, adding everything up, but it is very, very important. And the reasons why are because we can have a problem if the hourly maintenance is off. They get fluid overloaded or fluid down very quickly if there's excess bleeding or drainage from the chest tube or urine output. So this is all really, really important to be doing every hour. There's a formula, of course, for maintenance, and I put it on the side here. The one on the side in the pink area is for daily maintenance, but if you want just a general estimate in your mind of how much hourly maintenance a kiddo is on, there is the 4-2-1 rule that is over here in the bubbles. So if I weigh 8 kilograms, 4 milliliters times 8 kilograms, 32, that's about what hourly maintenance should be. If you figure it out the other way through the long formula, often it'll come up maybe 0.5 or 0.4 of a decimal off, but it's very close. So we want to do both, of course. And of course, the intensivist will order fluid as well, but it's helpful for them if we have an idea, since we're the ones at the bedside doing the hard work, to know how much fluid a kiddo should be on. So then if you have a 20-kilo baby, or let's say a 22-kilo baby, a little bit more math, then 4 milliliters for the first kilo up to 10. So always everybody that's under 10 kilos or around 10 kilos is only that 4 times whatever they are. So if they're 22 kilos for the first 10, that's going to be 40 milliliters, right? 40 times 10. And then the next 10 is 2 milliliters per kilo. So then that's another 20. So that's 60 mils an hour is their maintenance. But if they're 22 kilos, then anything over 20 kilos is 1 mil per kilo. So a kiddo that is 22 kilograms should have 62 mils an hour of IV fluids. Once you do it a million times and you figure you can do it easily, but it's just something to write down I write it down jot it down just on my little report sheet after I'm settling a kid back from the OR, or if we have a kiddo in the ICU before they go to surgery, just a general idea so that I know how much they should be, around about how much they should be getting in per hour. Now, something else to think about with that is if you have a kid that ends up needing blood cells or platelets after surgery, we have to take that into account also. The problem with taking away their maintenance fluids during the time that they're getting a transfusion is then they're not getting glucose unless they're eating, right? So we have to kind of always balance that in the ICU. Do they need volume? And then we can give them their maintenance fluids plus the packed red blood cells, and that is completely fine for most kids. But if they're a tiny little baby, maybe, a 4-kilo kid that just came back from a PDA ligation, that baby shouldn't have, if that baby is 4 kilos, then we know that 16 mils an hour is about what that baby should be getting. We should not be giving that baby 100 mils of PRBCs plus maintenance fluids each hour, right? So we just have to think about the size that the kiddo is and about what their body needs per hour. Now, again, when they start eating, they don't do this math. They're not thinking about how many meals they need to take if they're hungry. We can have some 4-month-olds, you guys know, they can take like 8 ounces and you're like, I don't know where you just fit all that, but they can do it. And so when they take that much, then we need to start cutting back on our IV fluids, right? And of course, this is a constant discussion with the intensive care unit doctors as well to say, hey, this baby just took 8 ounces. Do you want me to turn the IV fluids down? Should we give a dose of Lasix? And there's always a discussion back and forth about fluid maintenance. And again, just like I said with the chest tube output and the bleeding, they don't show us right away that they're dehydrated. So unfortunately, if a kid comes back from the OR and they're not meeting their maintenance needs because of whatever reason, they're having excess output from their chest tube and maybe they're peeing more, they will not show us right away. And so we want to make sure to keep up with this each hour on our flow sheets and in our minds and our organization so that we know, hey, this kiddo is about 100 positive for my 12-hour shift, just so that everybody knows. Or if they're negative, we need to keep an eye on that because we don't want them to get maybe that next dose of Lasix. So this is why it's so very important in children to watch this a little bit more closely than it is in adults, especially, like I said, those little babies. Now, once they get to be teenagers, very often they'll tolerate, whatever maintenance they want. I have pretty much 20 ounces of Starbucks, when I can every day, especially at work. And so my body knows that's part of it, and it easily is able to adapt to that. But just think about these kiddos having long-standing heart disease, many of them, and many of them having some sort of element of poor cardiac output and congestive heart failure. And so that's why we want to make sure to be really, really watching them closely when they're with us in the ICU. This is actually my baby when she was a baby. She's not anymore, but I had to fill in some pictures. So one of the things that we'll talk about, which unfortunately happens at night, so mostly night shift for those of y'all that are going to be working at night, because it often happens about 6 to 8 hours after surgery, is something called low cardiac output syndrome. It doesn't happen a lot, but one of the reasons that we need to be so cautious about watching their output so closely, and why we hammer that in, and why we're constantly asking about urine output and chest tube output and all of those things, are because when this happens, it is again last minute, and it suddenly becomes urgent to treat it. And so it's often 6 to 8 hours, like I said, after surgery. And you guys know these kids get back from surgery usually at the earliest around 12 p.m. noon. And so this usually happens at night when it's a little bit more calm. We never say quiet in the ICU, because some of those kiddos, they don't understand that at all, right? And when you say that, then we end up getting problems. So we don't say that, but oftentimes it will happen at night. What studies have shown is that you can kind of think about the kids that are a little bit less nourished, like that they come in with a low body weight. Even if it's an older kid, maybe like a 4-year-old with an unrepaired VSD, he's already got heart failure, right? Just by the nature of having that VSD for all the first 4 years of his life. So he's probably not super well nourished. He's not going to be like a chubby kid coming in. And so if he comes in with already a little bit of a lower body weight than he should have, he's going to be a little bit more at risk for low cardiac output syndrome than somebody that's a little bit more healthy before surgery. Also, when we talk about shift to shift report, which we're going to do next month a little bit more closer to the time that we're coming, that oftentimes part of the sign out, when the surgeons and the anesthesiologists sign out the kid coming back to the ICU, they'll talk about cross clamp time. And I remember when I first started working in the ICU, I didn't really, in my mind, it wasn't as important to me to remember that or to think about that. But the more that I've learned since then, that can determine how my night's going to go. So I do think about it a little bit more, because the longer the cross clamp time in the operating room, the more problems the kiddo can have. Now, can we help that? No, we can't change the cross clamp time. Of course, Dr. Soto and any cardiac surgeon would want the least amount of cross clamp time that they could have in order to do the procedure safely. But sometimes that's a lot easier said than done, right? They're operating on this tiny almond sized heart that has holes in it or has vessels going the wrong way. And so they need that time on cross clamp, which is where they're basically on the bypass machine, and blood is not circulating naturally through the baby or child's heart. And so the amount of time that they're not receiving that is the cross clamp time. Now, they're still getting the bypass machine blood, so that's all still circulating, but that is not normal circulation, right? So they're having a decrease in the blood that goes to their brain during that time and their end organs. So there can be problems with the kidneys after surgery, of course. Many times we see our kiddos' BUNs and creatinines go up, and that's why we're watching those labs every day. And also, like I said, the longer the cross clamp time, the more they're at risk for having this low cardiac output syndrome. They also have done all of these studies where they know that children that have heart disease also tend to have thyroid issues. So many of our kiddos that we'll be taking care of may have hypothyroidism. Some of it may be already diagnosed, some may not. But when they draw baseline labs, like the hormones that are supposed to stimulate the thyroid, they often have levels that are off. So if we happen to know that, or if those labs have been done before the kiddo has surgery and they already have hypothyroidism or not as high of a T3 or T4 as they're supposed to, then they also are more at risk for this low cardiac output syndrome. And again, it doesn't mean that every low weight kiddo that has a long cross clamp time is going to have it, but that we can kind of have an idea in our mind. Okay, This baby had a little bit of a rough day with surgery. He was already a little bit undernourished. He was on cross clamp for 40 minutes. Then we kind of have an idea, okay, we need to have in our minds that we need to have some extra fluid close to the bedside, maybe drawn up, not drawn up, but we at least need to have it. We need to be aware that we might end up having to give blood tonight. You know, just kind of have those things in your mind that you want to have in your back pocket in case of an emergency. Again, not always easy to predict, and we can't do it every time, but it's so much more helpful to have an idea that we're going to need to do it and have those things close than running across the unit to go grab stuff at the last minute. You guys know that it's not fun to do that. So there are definitely hemodynamic issues that occur in somebody that has low cardiac output syndrome. First, we might notice that their chest tube output's fine, but their urine output is starting to drip a little bit. Their oxygen saturations are starting to drift a little bit. Maybe it's a kiddo that came back from the OR in room air, and now we're on 2 liters of oxygen and they're not peeing as much as they were. That's when we need to start thinking, okay, there's something early here that's going on where the heart is not providing enough blood to the organs to meet their demands. And so that's why the physiology of all this is so important, but we're on the other end in the unit watching that urine, watching how the kiddo is breathing, right? So we're seeing those ins and outs of every minute. And that's when we can talk with the intensivist and say, hey, I'm really worried. These things are happening. And should we do an extra blood gas, or should we, check BUN and creatinine and see what's going on here? Sometimes these kiddos will end up on inotropes. Many times fluid initially will help if we can catch it early enough to give them some fluid back, but it is variable. Again, not super common, but definitely a lot of nurses joke that they come back from the OR looking great and surgeons give sign out and everything's fine. And then 8 hours later is when it falls apart. And that is pretty true for several kids with cardiac surgery. But if we're on top of it and we can keep up with their fluids during the night, then we usually have them looking good by the time the surgeon comes back the next morning, right? You just sit there and smile. Everything's fine. We're all good here. So it's not lying, it's just not telling all the full details sometimes. I went ahead and just put this chart here. You guys know that I'm like a picture person and I love charts, but if they've been on bypass, I have, I should have shown y'all too, these pictures that talk about the physiology of what happens to the cells when a kid is on bypass is crazy. Like, it's all of this huge cascade of inflammation and cytokine release from the plastic, basically, of the bypass machine, right? Like, even though it's this brilliant machine that circulates blood instead of the heart having to do it, it is not physiologically correct. It is not normal, and it's full of plastic. And just by running the blood through the plastic tubing of bypass, it starts a huge cascade of cytokine release, which starts a huge cascade of inflammation on top of the fact that they've had surgery on their heart, right? So all of these things come together for low cardiac output. So I just think it's so interesting to kind of take a look and think about all of these things that are happening to this baby's body after they've had heart surgery. And like we talked about last month, if they have a rhythm disturbance, like with AV block or a junctional arrhythmia after surgery too, that's going to make all of that even worse and heighten those problems. And so again, it's just something for all of us to be thinking about and kind of anticipating that we may end up having problems with these kiddos that have a long bypass time and maybe not the perfect preoperative course because they were underweight, which is normal for somebody that's had heart disease. So we've talked about the pulmonary vascular resistance, systemic vascular resistance. Again, it's so cumbersome sometimes to think about everything that's going on, but there are some things here in this factor list that we can do something about. So that's kind of what we're focusing on today. Hypoxia, we can work on that, right? We're nurses, we got oxygen. It's one of the most important things we have. It is a drug too, and we need to think about that, especially for our kiddos that we don't want being hyperoxygenated because we don't want to flood their lungs, depending on what kind of underlying disease they have. But if we have a VSD kiddo that comes back from the OR with a VSD repair, their saturation should be normal, right? Or at least in the 90s now. So if he's drifting down into the 80s at night when he's asleep, absolutely, we can talk to the intensivist and provide oxygen for that kid. So by us providing oxygen, then we will hopefully not have the increased pulmonary vascular resistance. The reason why we check gases so often is the same thing. If their pH starts drifting down, and we get a pH of 7.25, then we start getting anxious about that, because when we know that acidosis is causing issues with the cells delivering oxygen, and acidosis makes our pulmonary vascular resistance worse. And so these are the things that we can do. If we have a toddler that looked really good after surgery and now it's 2 a.m. and he's not really wanting to eat and he's very fussy, and we've already given him pain medicine and mom's at the bedside and we're doing those types of things, we have to start thinking about maybe we should get a blood gas, because the blood gas oftentimes, even though it's not super fun always to find the cartridge and get it drawn and do the things, and we're thinking about extra work, it's important because it can give us an idea. Okay, the pH is starting to drift down from what it was. The CO2 is starting to drift up a little bit from what it was. And so what can we do right now to help get that pulmonary vascular resistance down where it needs to be, make him more comfortable, and kind of catch things before he falls over the cliff and starts having a low blood pressure and starts needing to go on epinephrine and all of those things that happen in the ICU. Now, sometimes we can't help any of that, but if we can, if we start recognizing these things early, it will help. Atelectasis. We're going to talk about getting up and ambulating after surgery in a minute. And so that is so important. It doesn't generally happen that first night, but maybe the next day. It hurts when they cough. I mean, I can't imagine. I haven't had my chest opened, but I can't imagine how that feels, right? And so a lot of smart children, which all of them that I took care of in Guyana were, where once they cough, they realize that hurts, so what do? Then you quit coughing, right? Because it hurts. And so that's when we can come in and teach them and teach their mamas and fathers how to splint when they cough, and we'll make them a little pillow to hold over their chest for when they cough. With the teenagers, we often have to get a little bit mean to them, a little bit of a mean mom, attitude, which I can give y'all if you guys need it. You just call for me, I'll come in. And, no, I know it hurts, but this is what we're going to do. You're going to get up on the side of the bed and we're going to go for a walk, because we know that they're hurting. And I absolutely, feel for that, but they cannot get atelectasis and not take deep breaths, because then we're going to have a whole nother problem, right? So these are all the things that we're doing and that we're so amazing at, being nurses and who we are, for a reason, right? So we're giving pain medicine because we are trying to help the systemic vascular resistance not be increased. It's like crazy to think about it when you think about the physiology behind it, but that's what we're doing. So that's the reason why it's so important to just be on top of those things each hour in the ICU, or more often if we need to. There's some another list here. Another thing that we won't use super often, but we might use, especially on some of our intubated kids, is propofol. And those of y'all that take care of adults are quite familiar with that. We don't use it as much on children, but over the past several years, we started using it more and more. Propofol in itself is an absolutely great drug. Anesthesia loves it. They all, use it routinely. However, it can cause acidosis, and it can decrease your systemic vascular resistance. So you basically wash everything out, and kiddos can become very hypotensive with it. So these are all things that we need to be thinking about. If we have a kid on sedation as well, yes, we want them comfortable, but are we doing too much? Are we creating too much of a cascade or a problem here as well? So that's just all things that we need to be thinking about, and kind of the physiology behind it. Again, we talked about it usually happens early in the nighttime, or sometimes 18 hours after surgery, that low cardiac output can occur. And all of those things that we just looked at on the chart can happen. But recognizing those little subtle signs early is going to be the biggest, most important thing to think about, and to be notifying our intensive care unit doctors about and talking about. The great thing about the ICU, especially the one there in Guyana, is we're all right next to each other, right? And so if I have a baby that I'm a little bit worried about after surgery, there's always 3 friends, sitting pretty close nurse-wise that I can talk to. And that's so important to have, to bounce ideas off each other. And I can turn around and say, he just doesn't look great. I've given him a couple of doses of morphine. I don't know. Can you think of something else? And my friend might ask me, hey, maybe what's the last gas? Is there any acidosis? And I'm thinking, I haven't done a gas in 4 hours. Maybe we should do one now, and so it's just so important to think about those things and talk about those things. We already talked about all these, but just another recap of kind of what we can do if we're concerned about low cardiac output. You guys see them come in often with the echocardiogram machine in the ICU. They do echoes also in the OR, generally right after surgery. So many times in report, we'll talk about the anesthesiologist will pass off the echocardiogram after surgery, but we always have that ability to get that the next day as well. Usually not during the night. It's not quite as easy unless one of the intensive care unit doctors can go grab the machine and run it. But having an idea of what the echocardiogram is looking like too is maybe the VSD patch is leaking a little bit. Maybe there's a residual hole somewhere that we didn't know about before the surgery. So that's what we can get into as far as an echo that we wouldn't be able to tell, of course, without that picture. The most important thing, the goal here, what we're doing is just managing oxygen consumption, oxygen delivery. Sometimes easier said than done. It's not just putting a kiddo on oxygen, especially if it's one of those children that we don't want on a lot of oxygen to flood the lungs. But the things that we can do something about especially is the consumption part. If a child is hurting, their oxygen consumption is going to go up. If a child is febrile, their oxygen consumption is going to go up. So if we start noticing the child creep up in their temperature, which is normal after surgery, just so that everybody knows it is normal for children to have higher temps after surgery. But if we can get that fever down before it gets too high, then we are helping hopefully then stop that cascade that continues on to low cardiac output syndrome. So that's our goal. And then a little bit of a whiff of nasal cannula is never a problem. If we have a kiddo on the ventilator, do we need to be adjusting their tidal volume? Do we need to be adjusting their PEEP or their oxygen as well? We don't want them on 100%, obviously, but maybe they just need a little bit of a higher PEEP to open everything up if they're getting some atelectasis. And so again, these are all things that we kind of keep in the back of our mind if we're worried about our kiddos. This was another great picture of kind of things that we can do in order to help a child that has low cardiac output after surgery as well. I thought this was a great drawing. I cannot draw. I wish when I see these things, sometimes I really wish I could have these clever ideas, but I don't have them. So I'll just use other people's. Inotropes. Now, so not only for low cardiac output syndrome, but many times we'll have our kiddos come back from the OR on inotropes. So it's going to be something that we're managing a good bit. Epinephrine over the years has become a lot more popular than dopamine. When I very first started nursing many years ago, dopamine was something that we used on all of our cardiac kids. We don't use it quite as much anymore. I would say more often the surgeons want them on epinephrine. It feels a little bit stronger, like a medicine that has more side effects and so on, but really they found that having a better catecholamine release in the inotropes, the effects of that after cardiac surgery, the epinephrine works better for these kiddos. Anybody that's on epi, anybody that's had an adrenaline surge knows that it makes them tachycardic. So it is important to keep an eye on that. Although having tachycardia alone is not a problem for most babies, right? We already know that their heart rates run high as it is. But in being on epinephrine, you're also increasing the oxygen demand of the actual heart itself, right? Because it's beating faster, it needs a little bit more oxygen. So these are all things just to kind of keep in mind if you have a baby on epi. We try to do the lowest dose possible in order to maintain the cardiac output and the blood pressure where we want it. So we don't want to put them on high doses if we can avoid it, because high doses then will also decrease that systemic perfusion. So their kidneys, the end organs aren't being perfused as well if they're on higher dose epinephrine, and also their peripheral pulses and their capillary refill and their periphery won't be good, right? Because the body is trying to take that epinephrine and send it all to the heart to be able to squeeze the heart better. So if you have higher epinephrine doses, you probably are going to have lower output on the babies and their peripheral perfusion won't be as good. So that's absolutely something that we need to be monitoring. If their hands and feet start getting very cold and their capillary refill is delayed, that we need to let the intensivist know about. Dopamine doesn't tend to do that quite as much, but again, it takes higher doses to have the same effect that epinephrine does. and it doesn't seem to be as effective. We will use it to increase the contractility of the heart. But again, I think that we'll most likely see epinephrine with our kiddos coming back from surgery. We will try to get that off as soon as we can. So that's also something to keep in mind, that we're having discussions with the intensivist about what the blood pressure is doing. If it starts getting high and the baby's not in pain, then maybe it's time to start weaning the epinephrine. And so the goal will be to get those continuous infusions off as soon as we can. Not until it's safe, of course, but that will be our goal. Many of these drugs can run together, and we'll talk about compatibility and all of those things when we're there on site. But oftentimes they will run together. If you're going to have an epinephrine infusion going, you need to have a central line. It can cause tremendous damage in peripheral IVs in kiddos. Sometimes worst case, and that's all we have. It's something that can be done, but it's not something that's safe for the local tissues in a peripheral IV. So that's something to keep in mind as well. Other medicine that we use all the time post-operatively will be milrinone. We will use that on a lot of our babies after surgery that will then transition to oral medication following several days. Milrinone reduces afterload of the heart and also helps the heart contractility to be much better. So it helps the squeeze of the heart. However, in reducing afterload, what milrinone does almost always is decrease the kid's blood pressure. So it's something that we need to keep in mind. If we have a kiddo that we start on milrinone, and about 4 hours later, after it really hits there and gets in all the cells, they start dropping their blood pressure, that's going to be an expected side effect. It's not always pleasant, and many times we'll have to adjust the dose, but that's one of the things that is evil about milrinone, even though it's a great drug. It does improve the myocardial performance without increasing that oxygen demand. So unlike epinephrine and dopamine, which make the heart have to work harder and demand more oxygen, this drug does not do that. So like I said, it kind of depends on where you are in the child's course post-operatively, whether we're going to use it or not, but we will use it very commonly in children after surgery. Starting dose is 0.5 to 0.75 micrograms per kilogram per minute, and that certainly does not need to be memorized, but it's something to keep in the back of our minds if we have a child that's on more than that or a lot less than that. It's just something to kind of keep in mind what the normal doses are for babies. And then usually when you change the drug, the effects don't happen for 3 or 4 hours. So it has a longer half-life and a longer time to where it gets to peak effectiveness. So I feel like I skipped one. Oh, no, there it is. Sorry. It was down y'all are in my box at the bottom, so it was covering it up. So tamponade, we talked about a little bit a minute ago. This is fluid that gets around that pericardial sac, around the space that makes the heart not be able to constrict and contract as well as it should. It could happen following any cardiac surgery, especially anything where the surgeon went through the mediastinum, of course. And how we would know that a lot of times would be that we're not having chest tube output, or if it's a kiddo that doesn't have a chest tube, if I'm listening this hour to breath sounds and everything, perhaps the heart tones don't sound as strong as they did or as close as they did the last time that I listened to them. And so now I'm really concerned, is there something going on where there's something building up around the heart? Again, babies don't drop their blood pressure right away. And so I thought this was so interesting that 64% of children that have tamponade can keep their blood pressure up over 100, even with active tamponade. So we're not going to see hypotension until it's really, really late. We're going to see that decrease in chest tube output and have other signs likely before we're going to see them. Jugular vein distension is not something that you very often see it on children at all, but if they started having that, then that would be concerning as well for excess fluid around that pericardial sac. Tamponade is an emergency, y'all. There's nothing that we can do from a nursing standpoint for that. So it's just something that we need to help recognize early and make sure to be talking to the intensivist about. This was kind of a good picture of what tamponade looks like and how it can come about after surgery. How that fluid, you see that fluid as it builds up around the heart is just making the heart have a much harder time squeezing. And so that's where the problem comes in. There's always a little bit after any kind of surgery because inflammation and fluid buildup is common. But if it gets big like this, the heart can't squeeze and do what it needs to provide adequate cardiac output. All right, this was one of my favorite kiddos too. She's so cute. Pain management, one of our other big jobs that we do post-operatively. Almost all of these kiddos are going to need some sort of pain management, right? You can't have a big, huge surgery like this and have a giant chest tube coming out the side of you and pacing wires and everything else without having some pain. Many times they won't need a continuous infusion, likely unless they're intubated. Sometimes teenagers end up needing a little bit of a continuous infusion for the first little bit, which is totally understandable and fine. But oftentimes we manage these kiddos on PRN or as needed doses. And then they have done many, many studies that have shown that if they're able to take an NSAID like Toradol or Motrin, that many children after surgery do not need as long of narcotics. All the narcotic problems that have come mostly from the United States over the past several years, many of them have to do with adults and not as much with children. However, unfortunately, it's getting to where also we don't want to start habituating any of these children early, despite the fact that they've had surgery, and absolutely we're going to treat their pain. We don't want to give them prolonged narcotics. That is always a goal. Having a kiddo, especially in the ICU, that is very sick and prone to having ICU delirium and all the things that come along with critical illness, and then adding an addiction to narcotics on top of that is not good. So there's constant work being done on that and how to avoid that. Now, most of the kids that we take care of will not be intubated. We'll have a couple that'll stay intubated after surgery and that we'll have to extubate. Like I said, those are the ones that are going to be on continuous infusions of a narcotic and a sedative. But most of our kiddos will probably need some doses of PRN narcotics, and then we'll try to get them on Tylenol and an NSAID if it's okay. There always is a debate about NSAIDs. Can you give a 4-month-old Motrin? And many pediatricians will say no, even though studies have shown that it's okay. Generally, we say 6 months and older before we're giving Motrin. So we're certainly not giving Motrin to infants because it can affect platelets and it can have some bleeding side effects. And so we don't give NSAIDs to infants. So that makes it a little bit more challenging. If you have a 2-month-old that's had an ASD repair, then many times they're going to get narcotics and Tylenol after surgery because we can't do Motrin. So maybe just a small dose of fentanyl or morphine as needed, rather than a continuous infusion and then Tylenol. Older kiddos that are close to a year old, they might not be on narcotics for more than 12 to 24 hours after surgery. So that's always the goal. And this little baby, we could use lollipops. So see, those things work too. So other things, distraction, and non-physiologic things also help too with pain, just like they do for all of us, for adults as well. I put some kind of non-pharmacologic things that we can do and we will be doing, but of course, if they need pain medicine, we're not going to withhold that. For infants, many times the pacifier is golden if they like their passies, and giving that to them and swaddling them up and giving them, a little bit of rocking the bed and just being there will help them calm down. If they're infants that are breastfed, many times get helping mom, which is uncomfortable for the parents too, right? They're hooked up to all these lines and they have an incision on their chest. And the poor mamas are so scared about holding them. But if we can help with that and get the baby to nursing again when the baby's able to take PO, that works so much better than any pain medicine that we're going to give, right? Because that's their normal and that's how they're comforted. With toddlers, it's kind of that distraction stuff. Getting them to blow bubbles is actually excellent because not only does it distract them, it also helps with their incentive spirometry. They would much rather blow bubbles than pull on that dumb machine. So they like that. And then helping involve them with toys and books and, of course, treating their pain as well, but also just having a conversation with them and being active with them and doing the things that they can do in the ICU is important. Older kids, books, games, coloring, all of those things are very, very important. And then adolescents want their phone. You guys know that. So if they can be after surgery on their phone in the ICU, then we let them do it, right? Because even though there's rules about screen time and all those things, when you've had cardiac surgery, that doesn't count, So if they have time to be able to be on their phone and that helps distract them a little bit to feel more normal, then that's something that we'll do. That's okay. And we will fight for that if we need. For the narcotics, like I said, we are going to use them, and it's important to use them. You know, it's not that we're not going to give them at all. We just want to make sure to stop those as soon as we can following surgery. Fentanyl and morphine are going to be the most common ones that we give while we're there, that you guys will be giving. The biggest, most important thing to remember with fentanyl is that you don't want to push that quickly. And I actually have another slide that talks about that a little bit. Actually, truly any narcotic in children, we don't want to push too quickly, especially those that are naive of narcotics, because they will have bigger side effects from those normal side effects. Morphine can cause itching, right? And morphine can make you nauseated. And those are normal side effects of those drugs. But if we can give it a little bit slower, a little bit more gently, maybe give Zofran before we give the morphine, we can kind of help allay those side effects a little bit. Sedatives that we use when we have a child intubated or when we have a child that's just out of their mind are important also. Versed is going to be one of the most common ones that we'll be using. And then Precedex is also another great drug that we will use as well. And I have slides for all those, so I won't talk too much about those. But then the analgesics too, like I talked about. One of our anesthesiologists here at the hospital where I work in Texas did a big study a couple of years ago on actually about the toddler age to early school age. Giving scheduled Tylenol and Motrin was actually more effective in postoperative pain than giving a kid narcotics. So it was so interesting. And she really pushes that now to where any kid that she's done anesthesia on for surgery, if the surgeon's fine with it, will get every 6 hour ibuprofen and Tylenol together for 48 hours after surgery, no matter what. And that seems to really help the number of narcotics that they have. If they don't have to get the narcotics, they don't have the nausea that's associated with them, and then they hopefully don't end up with the constipation. So it has been a really good thing that we've done here, and hopefully, again, we can kind of work towards those analgesics. And the kids will go home on them as well, of course, after they've had cardiac surgery in Guyana. But you don't want to, be giving IV fentanyl every 2 hours for the first couple of days for a kid that's had cardiac surgery and then turn around and discharge them on day 3, right? That would be terrible for the parents to have to deal with their rebound pain, and then also probably the constipation that came along with all of that narcotic too. Another IV analgesic that we can use is called Toradol, and we will probably use some of that too. Risk of bleeding with that. However, again, we use it in postoperative cardiac surgery all the time without any excess bleeding. And so it's just something to be mindful and think about as well, because if we can use an analgesic rather than a narcotic or a sedative, that's going to be much safer for the kiddos. This is our FACES scale that we use for our younger kids. It is so funny to me, even when you explain 10 is the worst pain of your entire life. Almost all the school age teenagers are like 10, and you're like, really, 10? But you can't, pain is subjective, so you can't judge them. But you're like, come. So I do have one of our brain surgeons actually that I work with a lot who will be like, 10 is like your arms being ripped off, drugged by a truck. And I'm like, okay, that's a bit dramatic. We probably don't have to go that far with them. But the FACES scale helps in the younger kids, and sometimes even school age kids that have a hard time knowing. I even get anxious when they ask me. I'm like, I don't know what number it is. You don't want to be too much or too little, but this kind of helps us to know. The one thing about all of our scales that we have for pain, again, is that it's subjective, right? Like, I can be sitting here like totally stone faced, look normal on my phone, but still be hurting. Whereas somebody else may be in tears if they just have a little bit of pain. Everybody's different, right? So we absolutely need to trust the kiddo and their parents when they're telling us about how much pain they have. And we do need to take that, into account and treat that accordingly, right? We can't decide for them that they're hurting or not. So it's important to have these scales, but also to remember that it really is up to them. Here's fentanyl real quick. This is one of the ones that we're going to be using a lot. Normal dose is 0.5 to 1, and that can vary micrograms per kilogram of their body weight. We usually try not to use it more than every 2 to 4 hours. It's very short acting though, right? So if you give a PRN of fentanyl to a baby that's not intubated, it's only going to last an hour or two. Oftentimes on a baby that is intubated, the intensivist will let us give fentanyl even every 15 minutes because it is short acting. And if you're needing it to help them from moving too much to keep the endotracheal tube in place, that is perfectly fine to do that. In one dose, it does max out at 50 micrograms. So if you have a bigger teenager, you don't want to just be going on their kilogram body weight for all of their drugs because it does max out. You try not to give more than 50 micrograms at a time. I put the infusion doses here as well. It's kind of something that we always are titrating according to how the child is affected by it. They become relaxed with it. They can have euphoria, which is what we want. It relieves their pain. It also has a sedative effect as well. The problem is coming along with that are the other problems that narcotics have. They can get super confused. They can feel really dizzy if they're awake. It can cause nausea and vomiting, which very often in narcotic naive kids, morphine and fentanyl both do. They can retain urine. So if you have a kiddo that's a couple days after surgery that's not, that already has their Foley out, we need to make sure to be checking on their urine output because they can retain urine and they can get very constipated as well. This is kind of what we were talking about earlier with the side effect of fentanyl. It's only happened to me one time in my nursing career. It will never happen again. I was in the cardiac ICU taking care of a kid with an open chest. So it was a kiddo that they couldn't close the chest on after surgery because of swelling and arrhythmias and stuff. And so I was anxious already, right? Because you have this dressing over this open chest and he was moving way too much. His ET tube was moving around in his mouth. It needed to be retaped and I was anxious. So I slammed the fentanyl in. I will not lie to y'all. After I flushed it, which I also flushed it quickly, there was nothing we could do to get that baby's chest to move on the ventilator. It was so scary. Generally, it's short acting. If it's going to happen, it's called wooden chest syndrome. But if you push fentanyl too quickly, absolutely their chest can get very, very like stiff almost. I mean, it becomes tight. And no matter what the respiratory therapist does, it's very hard to bag through that. So it's just so very important for us not to do that and not to give it too quickly. And that's why. It happens a lot with younger babies or old people that get fentanyl when pushed too quickly. It doesn't always happen, like I said, but since I can't be the one that decides if it's going to happen or not, I'm never going to do it again. It only took one time for me to do that. And then you kind of have to wait out. Luckily, like I said, it's fast acting. So you kind of have to wait that out a little bit and just kind of slowly keep trying to bag them until their chest begins moving again. But it absolutely can even happen in awake kids. So that's the reason that we want to give it slowly. When I say slowly, I don't mean 15 minutes, right? You don't give fentanyl over 15 minutes, but certainly not over 5 seconds. So there's happy medium there. And some people feel most comfortable putting it on the pump for, 2 minutes. I feel comfortable slow pushing it, whatever your comfort level is with that when you're giving narcotics is fine. You just have to kind of decide your own role. And then remember that these doses are so tiny in babies. Like perhaps the fentanyl is 50 micrograms per milliliter. So if I'm giving 10 mics, I'm only giving 0.2 mils, right? So you give the 0.2 mils in a small syringe slowly. Where is all that fentanyl? In the IV tubing still, right? Because you have 2 mils of IV tubing there. So it doesn't matter necessarily if I come in, if I slam the saline, that's actually slamming the fentanyl, right? Because it doesn't matter how slowly I gave that 0.2 mils, it's still in the tubing. It's not in the child yet. So the flushes need to go slowly as well, or just be mindful of the volume that you're giving. If I'm only giving 0.4 mils, that's all in the IV T connector. It's not in the child yet. So then you want to flush kind of slow push, or you can put your flush over a 2-minute flush or whatever you want to do for these narcotics. Same for morphine. I put the dose here of what the doses are. This is a longer acting drug, and it's why we use it a little bit more often, a couple of days after surgery than fentanyl. It lasts longer, right? So a child can get relief for a longer time, often 4 or 5 hours before they need another dose. 5 milligrams is our maximum on that. So if we have a big teenager that's 100 kilos, we don't give them 10 milligrams. We give them 5. Slow IV push again with a slow flush is important. We can also give it continuously for our intubated children, and I wrote those effects down. Fentanyl, not as much, but morphine absolutely will cause hypotension. So it's something to be thinking about when we have a child that's hemodynamically unstable and on narcotic that's intubated. Now, we can't really help any of those things, right? But it's just something to think about. Hey, maybe we need to come down on the morphine a little bit to see if we don't have to adjust the epinephrine so much. It's just, if they're comfortable and if they're asleep. Also for our kids that are awake following surgery, giving them morphine can kind of decrease their respirations. And that can be okay as long as it doesn't lead to lower SATs to atelectasis. So we just need to be mindful of all of those things that can happen with these narcotics that we're giving. This is Precedex, which is dexmedetomidine, also amazing drug. It's more of a sedative than a pain reliever. Although if I'm hurting and I'm asleep, I'm probably not hurting as much, right? So we use it a lot in the ICU. We use it for awake kids too, asthmatics maybe that need to be on a little bit of BiPAP or continuous albuterol who are out of their minds, anxious because they feel like they can't breathe. Absolutely, a little bit of Precedex will help them relax. We use it a lot. So I hope that we'll have some with us when we're down there, and you can load it. We don't have to load it. Maybe the anesthesia doctors gave them a little load before they brought them over, but we can also use it even for our kiddos that we're trying to extubate. We can use continuous infusions of Precedex and keep it on them while they're awake too. So it doesn't make them so sleepy that they don't want to breathe. You can have an extubated awake kiddo on it. The maintenance dose, 0.1 all the way up to 0.5 micrograms per kilogram per hour. It's not given PRN. So again, it's a sedative, not like Versed. It needs to be continuous. It's not something that you just give intermittently. It needs to be continuous in order to provide sedative effects. However, little babies on Precedex can have severe bradycardia. So it's something that, in the back of your mind, if we have a kiddo that's on a Precedex and he's 4 months, 5 months, 6 months, and his heart rate starts dropping, it's not, fun to play that game. And so we'll be talking to the intensivist if we notice that the heart rate's less than 100, because unfortunately that is a common side effect of Precedex. Doesn't always happen, but it can for sure in the babies. Versed, another drug that we use a good bit in the intensive care unit. I will tell you all, the crazy thing about Versed is though, some kids, the kids that go crazy when they get Benadryl rather than get sleepy, which isn't that common, but does happen often, those children also will do the same thing with Versed. So my niece, who's like this very calm, sweet little girl, had her arm broken about 4 years ago and had to have surgery, and they gave pre-op Versed. And I was sitting there telling my sister-in-law, I'm like, she's going to be so calm after this. She'll just go back to surgery. They'll take her in. She'll be asleep. She won't even remember leaving you. They gave her Versed and her head started spinning on her neck and she was screaming and she was cussing, and she never does any of that. So it can happen that it has the opposite effect. So we want to always give it knowing that it can happen in the ICU. It doesn't often happen, but it for sure can. But little doses, so only 0.05, sorry, to 0.1 milligram per kilo of Versed. And then we'll often have our children on the sedative Versed or Precedex as well as the narcotic if they're intubated after surgery too. It can actually help with seizures too. And our chronic kids that have epilepsy, the older kids, they used to have, their rescue was always Diastat. And for Diastat, it has to be given rectally. So you'd have this like teenager who's having a seizure at the mall or at school, and they would have to give them Diastat rectally for their rescue. Now, the amazing Versed company has created a nasal Versed that they can actually give for rescue for seizures. So just interesting that they've done that. And so it does stop seizures as well. And it's used for that in epilepsy and seizure world. The side effects of respiratory depression, definitely. So we want to be careful giving Versed to anybody that's not intubated, but they often use it prior to surgery to be able to give the kids or adults and help them relax a little bit before they take them away from their family and take them into the OR. Analgesics, this is what we're going to kind of be focusing on, what we're really going to be using post-op day 1, post-op day 2. I put the normal doses here. And then now we have IV ibuprofen, which we've never had all the years I've been practicing before, most recently. And so we have IV acetaminophen and IV ibuprofen if it's available. We can give both of those IV if we have a child that's not tolerating PO yet. But Tylenol and Motrin are going to be our go-tos after surgery, and they can take them up to 10 days after surgery generally without any problems. That will always need to be a discussion with the surgeon and with the medical team, but many times they can have them when they need them, right? I'll often tell families before they're going home, you don't have to give Tylenol every 6 hours if they're not needing it. You know, the kiddos will be very good about telling you. It's one of the reasons I love taking care of children, because they're going to tell us if something is or isn't working. So if they're going to bed at night and they don't need the Tylenol, they don't have to have it. But it's just important to for the family to know they've got something that they can do after they leave the hospital to be able also to control pain, because they will hurt, you know, for a while after surgery, especially having their chest, you know, opened. Toradol is ketorolac. It's the other name for that. And again, that's something that we'll be giving in the hospital. That's not something you can go home with, but that's also IV. So if we have a child that's just vomiting and vomiting after anesthesia and is not keeping stuff down, we will be able to avoid narcotics if we can. If they absolutely have to have them, we can give them with Zofran, but then also Toradol is a great medication to do because you can give it IV and it won't make them throw up more. Moving. This is one of my favorite patients that I took care of in Guyana. She had Downs and she could be so mean, but she would want to walk, and then we would walk and she'd go about 3 steps and then she'd do this. And so she and I had many discussions about that. She was so funny. But getting up and walking is so important. Helps with atelectasis. It helps them feel better. It helps them feel normal. And I think I told you guys this a couple months ago. They don't want to be in that ICU in Guyana because it's so freaking cold in there. They're like, no, I want to be out, you know, so they'll like point outside those green doors. That's where they want to be, in the open air ward where it's much warmer. But they're like, we don't know what's wrong with you people keeping this air conditioner on, you know. But getting up when you can get up and walking these kiddos is so important. Again, it's not super comfortable if you've never done it before, because they're hooked up to a chest tube. They've got all these wires. Their pacing wires are underneath the dressing somewhere on their chest there. So it's kind of like, how am I going to get this kid up and walk? But I tell you guys, once they take a couple steps and they realize that they feel better and that they can still do it, they just start going. She would whine and cry and do this and squat down and not want to get up in the hallway. But then like a few minutes later, she'd stand up and she would kick the little ball that we brought with us. So they want to be up and playing. My daughter got to come with us 4 years ago, and she had a little boy she took care of who she still contacts on WhatsApp. They still talk. He practically was playing soccer outside of the ICU with his chest tube in. I was like, you have got to stop moving so much, because he felt so much better once he was up and moving. So they need to be up. We need to get them up and walk them when we can. And that's one of our most important jobs as nurses, because we don't see the ICU doctors often doing that, right? So, and then also thinking about these kiddos that are on the ventilator, we need to be doing something that assimilates moving, right? So turning them every 2 hours, which is easier said than done. And I get that with an ET tube, if they start coughing every time we turn them, all of those things need to be, you know, you gather a couple friends and we all do it together, but we really need to try to be turning them every 2 hours. And then if they're on the ventilator for 2 or 3 days, we need to be doing range of motion with their legs, with their hands, you know, to try to keep them from getting stiff. As resilient and great as kids are, they also lose muscle mass very quickly and they get weak very quickly. And so we have to remember to be taking those ventilated patients and just moving them as much as we can safely, knowing that also after cardiac surgery, you're on the ventilator, just moving them and bathing them sometimes absolutely increases their oxygen consumption. And so it's a fine balance. Maybe give them sedation first before you start their bath at night, and then we'll get them turned and repositioned, change their dressings, do all that while they're sedated, you know, because that will help with their oxygen consumption. But that's just mobility is so very important. Dressing changes. Easier said than done. Again, like I said, this kiddo was so pleasant and happy, but you see those giant dressings on her chest. The bottom one is from the chest tube coming out. The top one is from her mediastinum. Generally, every kiddo is a little different, and Dr. Soto doesn't have a very strict rule about how many days, but usually we don't take the dressing off until the day before they go home. However, if the dressing is stained, which this one has a little bit of stain on there, you guys can see, he's going to want that changed. And so we will all be talking about that and practicing that in person while we're there. And as clean as it needs to be, which is, not super easy when they're eating, especially a baby that's dripping formula down there, but we can't leave it like that. And they are sticky and it hurts coming off. And so there's always techniques that we can talk about as well. But generally we keep them covered for 48 to 72 hours after surgery and then take them off. This is a little video. I don't know. Just real quick, we'll just watch this dressing change.
Now we're doing a wound dressing change for a surgical incision. So cats.
So we're going to have just a little bit of sterile water to clean the wound off. And then we've just got some plain old cover sponges and an abdominal pad in case I find that there's too much drainage and we need to soak some of that up. So then we're going to uncover.
All right.
And remove the old dressing. Now, normally you can put on whatever came off of it, is what you're going to put back. Then you're going to throw this away. And I'm going to clean her incision. Now, this is not a sterile dressing. I don't want to contaminate the inside of the cap, and I don't really want to contaminate this. These are actually pretty impermeable. So you could use that as a surface, but I don't need that much. Her incision looks great. So I'm just going to pour out a little. And then I'm going to be careful about how I clean this. I don't want to do this kind of motion, okay? Because then I'm dragging germs back in. And so for this kind of dressing, you can really just make sure that your incision is kind of midline and clean this direction. And then clean this direction. And there's a couple of different ways that you can do that and still be totally safe. So if this was a fresh gauze, I could also come this way and clean out and use a new surface and clean out. So either one of those is pretty okay to do. And so I'm just going to make sure that the incision gets covered back up well. And put a little tape on it. Again, if this is a mobile person, I want to tape it down better so they don't lose their dressing in the middle of a walk. But if somebody's just laying in the bed, you're going to use as little tape as possible to try to keep them from having skin issues from the tape. So
that's it.
Very cool.
She's holding a
One of
lot
the
more
last
still than
things
our
we
kids
do
are going to
is
hold,
go
obviously,
get a
but
side-
that's what we're going to be doing on those dressings that are saturated. That's how we're going to have to change them and what we're going to need to be doing for the ones that are saturated. Now, most of them, if they're not saturated or if we're taking them off because it's been 48 hours, we won't be putting another one on. And so we'll need to take that off. And then you guys can even see like hers here in this picture. Look at how big that is, and that is all very sticky. And so that process is not fun for her by any means. And so oftentimes a little bit of narcotic, if we still have it, if they still have an IV in place that's working, and just talking them through it, maybe having a video on one of our iPads so that they can be distracted by that, or working on a game with them, an I Spy game or something in a book, because it's a lot. It hurts to come off the incision. The part over the incision is telfa, so it's often not stuck to the incision, but if there's been a little bit of bleeding, many times it can be stuck. And so we're pouring the water or the saline over that so that hopefully we're not causing an issue. But like I said, it is more for these kiddos after surgery than getting up and walking. It is harder for them. It hurts more to change these dressings. And so it's going to be important to have kind of a team effort on that. The only dressings that we will change sterilely will be central lines. And of course, we'll do that in practice while we're there. But these chest dressings and the chest tube dressings, if we need to change them, they're not sterile procedures. It's just a septic procedure, so that we're doing that together. Nutrition, again, like I talked about, if we can feed them orally, we need to be doing that. Some of them want to eat that night after surgery, and often that's fine. Many times that's the babies. And some intensivists, depending on their practices, will do Pedialyte feed first, but Pedialyte is gross, and so some babies won't take it. We've also had some moms bring in coconut water, and we would give them that if it was okay with the intensivist as well, and then move to a formula or breastfeeding. Some of the intensivists just go straight to formula, so that has to be a conversation, but many times they can be tolerating formula feeds that night. And then the older kiddos are usually the ones that don't want to necessarily eat right away, especially if they're hurting. So sometimes there's a struggle between us being nurses and knowing that they need to eat and them not wanting to, because we know that once they start eating, they'll feel better, but they're not convinced of that because they don't feel good, so they don't want to eat. So it becomes kind of a struggle. You have to figure out what they will take and what, maybe ask mama what their favorite foods are, what their favorite thing at home is. And many times the parents, if they can, will bring something in, and that would be something that they're going to be more likely to eat if they're super picky about wanting to eat after surgery. But feeding them orally is always best. And then our children that are on the ventilators, we need to be thinking about having a feeding tube and giving them some sort of nutrition within 24 hours after surgery if we can, because that is the best thing to help them heal, is nutrition. This is a group of my girls from last time I was there. We have questions. I know I told you guys only an hour, so we'll run through these really quick, and then you can look at them when I send you the video, and I'll also send the hard copy just so that you can have them, and I'll put the answers on there. So if we have a newborn, 3.5 kilos when he was born, so pretty healthy weight when he was born. Mom comes to the pediatrician when he's 2 weeks old. He's been really, really fussy, and she's concerned about that. He's not finishing his feeds. He's sweating a lot. Also, he seems to be kind of tachypnic, and now the pediatrician is hearing a heart murmur. What does he probably have? If he had single ventricle, would he have made it 2 weeks being home without a problem? No, right? Because he wouldn't, no. So, and he would not have a cyanotic heart disease either, because he would be blue when he came in, right? He wouldn't just be tachypnic and have the heart murmur, and he probably wouldn't be eating at all if he had a cyanotic lesion. So this answer is going to be A, the acyanotic lesion. He might have a small VSD or an ASD that's causing him to not be able to breathe effectively because of his low cardiac output, which makes him not want to eat and makes him really, really sweaty. So this answer is A. 7-week-old with wheezing, coughing, and vomiting. You can't really feel the femoral pulses that easy. The liver is 3 centimeters below the right costal margin, and the blood pressure is higher in the arms than it is in the legs. You guys remember which one that was? That one is D, the coarctation of the aorta. Because the aorta is squeezed down after it leaves the heart, it's not delivering the appropriate amount of blood to the legs. So many times these kids will come in, and you guys know, those of you that have worked in primary care, if anyone has, like in a pediatrician's office, they're not always checking all of that, right? And it's not their fault. It's because they're seeing 40 babies in one day. And so many times, feeling the femoral pulses are not something that you would think about doing, but that's kind of just comes with experience and time, that if you have a baby that comes in with cold legs and has difficult to feel femoral pulses, you have to be thinking that the blood's not being delivered appropriately to the lower part of the body. And that comes from a coarctation of the aorta. Okay, we're in the ICU looking at a 2-year-old after surgery. We're thinking that could have cardiac tamponade, but which one of these things would not support tamponade? We said that they would have muffled heart sounds, right? That their neck veins would probably be dilated. They would not have elevated blood pressure with tamponade, because remember, the heart's beating up against that sac full of fluid. And so oftentimes their blood pressure is going to start getting low. So this one is B. They would not have elevated blood pressure, likely would have low blood pressure. A parent asks why we're doing so many chest x-rays after surgery. What should we tell them? Does the x-ray show the ribs and bones but not the heart? No, we know the x-ray shows the borders of the heart as well. It can't actually tell us about all the vascular anatomy of the heart. So it doesn't show vessels, right? That would be like a cardiac MRI or an echocardiogram. It doesn't show us electrical activity of the heart, but it does tell us about the heart size. So we know about how much fluid is around the heart, how big the heart is, how hard it's having to work. And we can also look at the pulmonary blood flow patterns, right? So the answer is D. It gives us an idea about heart size, any effusions or pleural effusions or pericardial effusions around the heart, and then shows flow of pulmonary blood flow patterns. Echocardiograms often done, of course, as well, but we do these chest x-rays every day, especially to look at lines and tubes as well on the babies after surgery. A kiddo comes from the cardiac surgery to the ICU immediately. What is our top priority? Always airway, right? PALS, CPR, all that, no matter what. They've had surgery or not, we need to make sure that the airway is patent, because if it is not, then nothing else is going to follow that cascade. So we have that normal routine that we always have, and we need to make sure that if they're intubated, that their ET tube is patent and that their saturations are okay, or are they breathing effectively? That's what we're going to do first, as we're doing all the other things that come along with taking care of a kid after surgery. Which nursing action helps decrease anxiety for parents who is scheduled for cardiac repair? So this is kind of like where that morning talking about the kiddo's surgery. Telling them not to worry because the surgeon does this all the time. That doesn't work, right? Those of y'all that have kids know that that doesn't work. Don't worry. No, I'm going to worry every day. Obtain an order for the parents to take anti-anxiety medication. God, I wish sometimes we could do that, but we are not allowed to do that. Sometimes I want to just give them a smidge of the Versed, but that's against all the rules, so we can't. Don't do that, y'all. We'll get in trouble. Teach the parents 1 or 2 months before the procedure. No. So yes, if we know that they're going to have surgery 6 months from now, yes, you can talk about it, and yes, you can give them an idea. But am I going to remember all that when you're stressed out? No, absolutely not. So the right thing to do that day is talk kind of about the steps that are going to be occurring. They're going to give him a little bit of medicine. They're going to take him away from you. And then you will see him again when surgery is over. He will come here to the ICU and you'll be allowed to come in. Just those short little steps of what to expect before and afterwards. That way they have something tangible to focus on. I will say, and Dr. Soto would definitely agree, you don't necessarily give them an exact amount of time that they're going to be away either, right? Because if they're gone longer than that, they're in there like, what is going on with the baby? Did something happen to the baby? Then they're freaking out. So a lot of surgeons will actually kind of overestimate the amount of time, or just say, one of my surgeons is always like, it's going to take me as long as it takes, which I think some moms aren't super happy with that either. But just an idea, if you think it's going to be around 3 hours, maybe you tell them 3.5 or 4. And that way, if they come out early, then they feel better, so those little steps and kind of little pieces, not that we're withholding information, but you don't want to go on and on and on about the arterial line and the catheter and this and the blood pressure is too much when their baby's having surgery. So little pieces of what to expect before and after surgery will help be a little bit more calm. Mom asks that why her child is squatting every time he runs and plays. What is one of those things that we learned last time that squatting does? It increases the blood flow right to the lungs. So those kiddos, especially that have tetralogy of Fallot, they need to do this when they're having what's called a TET spell, like Aaron talked about last month. So when they figure out, they're so brilliant, when they squat down, that their blood flow finally goes to the right place and gets back to their lungs and they can breathe easier. And it definitely happens with kiddos that have tetralogy of Fallot when they're more active. So they'll stop and they'll squat down and then they'll start up again. Start playing again often. A 1-month-old is admitted for VSD repair. What would we think that they would have beforehand? They shouldn't be bradycardic, right? Maybe tachycardic more than anything. They won't have bounding pulses with a VSD. They're going to have the murmur at the left sternal border. Again, you don't need to sit there and say, okay, I definitely hear this at the 4th intercostal space. You just know that if you hear a baby with a murmur, that there's a hole there. There's something that's not communicating the way it should. So the VSD kiddos will definitely have a murmur prior to surgery. They should not have one when they come back to us in the ICU after. So that's something that we need to be mindful of as well. 5-year-old with heart failure. what tells us about adequate cardiac output. Not their heart rate being that high, right? It shouldn't be that high when they're 5. They absolutely should not have a capillary refill of 8. Crackles tell us more about congestive heart failure, right? So this one's going to be urine output. So having a good urine output each hour of at least 1 ml per kilo. Oftentimes kids do more than that, but at least 1 ml per kilo should be our goal each hour. We're not always going to meet it. There'll be some hours with their Foley that they might have less, but that needs to be the average. All right, there's my references for today. You guys have any questions? Are y'all hanging in there? All right, y'all. Listen, I hope you have a great Christmas.